Good afternoon and welcome to Building Cyber Resilience, Navigating Healthcare's New Reality, a health system CIO production sponsored by CTG. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments anytime in the Q&A box, and we'll take those later in the program. Just so you see how we're going to spend our time today, we're going to go about 40 minutes with our main panel discussion featuring Keith Duemling, VP and CISO with Catholic Health, Karen Habercoss, VP, Chief Information Security and Privacy Officer with UChicago Medicine, Monique St. John, VP, CISO and Associate CIO with Children's Hospital of Philadelphia, and Chad Alessi, Managing Director for Cybersecurity with CTG. And then we will do our Q&A, audience Q&A. So let's jump right in. Keith, let's start with you. Can you give us an overview of your organization and your role?
Sure. Morning, good afternoon, everyone. Keith Duemling, Vice President, Chief Information Security Officer of Catholic Health here in Long Island, New York. We're a 6-hospital system, a little under 2,000 beds, serving most of the Long Island community for different types of healthcare needs. Excited to be here and talk about, our journey from a cyber standpoint and business resiliency. Got a smaller team compared to some other organizations, but, we're doing a lot of exciting things and, certainly keeping resiliency, top of mind. So.
Excellent. Thank you, Keith. Karen?
Good day, everyone. I'm Karen Habercoss. I'm the Vice President, Chief Information Security and Privacy Officer for the University of Chicago Medicine Health System. The University of Chicago Medicine is a not-for-profit academic medical health system based on the campus of the University of Chicago. We have hospitals and outpatient clinics, physician practices throughout Chicago, the Chicago suburbs, Northwest Indiana. The health system, along with our biological sciences division and our School of Medicine, have a 3-part mission: clinical patient care, research, and education.
All right, great, Karen. Thank you. Monique?
Hi, Anthony. Thanks for being here. Thanks for having me. I'm the Chief Information Security Officer of Children's Hospital of Philadelphia, fondly known as CHOP. We also have a 3-pronged mission of pediatric healthcare, research, and professional education. We have about 60 locations serving children globally, though, 3 hospitals, and over 30,000 employees.
Okay, thank you, Monique. Chad?
Yeah, good morning. Thanks, Anthony, and thanks to my fellow panelists. Great to be here this morning. Chad Alessi, I'm the Managing Director for CTG's Cybersecurity practice. CTG is a digital transformation and IT services company. We've been in business for over 55 years. We were a publicly traded organization. We just were purchased by Saheka, which is a global organization. We have about 10,000 employees worldwide. We have a deep experience here in the US, particularly in healthcare, and have worked with our healthcare clients for over 2 decades in helping them prioritize a lot of their security risks that they deal with on a day in and out basis. So on the security side, we focus from everything from helping organizations build resiliency across their environments, as well as helping them secure their identity and access management. We have 3 modern security operations centers that we operate here, 1 in the US and then 2 in Europe. And then we have managed third-party risk as well that we work with our clients on. So we support hospitals, payers, and public health agencies in developing cyber strategies to align with their operational priorities. So great to be here, and thanks for having me.
All right, thank you, Chad. All right, Keith, we're going to start with you. Just a basic introductory question. How are you defining cyber resilience? How do you think of it?
I think that's a good question. I think my definition seems to shift a little bit based on the different issues that we encounter. But I mean, at a high level, I consider it, the ability of our systems, technology, and our processes to withstand different types of cyber events and continue operating at optimal levels so that our caregivers can continue to provide the best care possible to all of our patients, both in person and remotely. And then in addition to that, resiliency is also recovering and returning to normal 100% optimal operations in the shortest period of time with the least amount of long-term impact from both a technology, compliance, and legal standpoint. So kind of a complex answer, but it's a complex topic.
Yeah, quick follow-up there, Keith. You talk about recovering and returning. Generally, do we think of, if we have to go to paper for a while, what do you think is the CISO's role in that recovery part, or helping clinicians think through the recovery part of getting that paper-based documentation into the EHR post-incident?
Well, I mean, I think the goal should be to avoid having to do that in the first place whenever possible. But, as part of that recovery effort, we're looking at, how do we re-ingest that information as quickly as possible with the highest level of accuracy? And are there alternative systems that we can provide that, maybe it's not a return to paper, but it's a return to a secondary or tertiary system that can be used when the primary systems are unavailable as well. Our goal is to minimize that disruption, if there is going to be one, to the lowest level possible. So it's not hey, you move from an era where there's electricity, now we're in the dark ages for the next, week or two until power is restored.
Yeah, and we'll get more into that concept, which I've heard referred to as the blast radius,
Yep.
and minimizing that and not overreacting and shutting things down that maybe you didn't need to. So we'll get back to that. But Karen, your thoughts?
Yeah, I mean, I think Keith is right. Cyber resilience is such a broad topic, and I think it means a lot of things to different people. But I think for me, it means trying to figure out what the current the current threat landscape is, and anticipate as much as we can what the future could look like in healthcare. And then I think Keith is right, trying to identify and proactively, as much as you can, address technology. I'm also in favor of addressing some of the human and operational capabilities as well, and ways that we can continue clinical patient care, minimize business disruption, respond to things, recover quickly, and then I think ultimately learn better for the next time or the next time, no matter how big or small.
Do you want to give me a little more info on the human and operational capabilities, what you're thinking around that?
Yeah, I mean, I think a lot about, so I think folks who know me know I was a clinician first and foremost. And so I actually think a lot, not only with a technological hat, but what does this look like for our clinicians? And so I think it's really important, and maybe unpopular sometimes as the information security officer, to actually get down with the clinicians to understand their workflows. And I think that it involves a lot, at least on my end, talking with our business continuity program, our emergency management program, and understanding the workflows. Because I think, one of the things that's unique about healthcare is we are so reliant on like electronic medical record systems and drop-down menus. And I know that most clinicians coming out of school in the last, I don't even know, 10, 15 years even, they wouldn't know how to document on paper, even if they were given a piece of paper. And so I think this is really challenging because they are very dependent upon the drop downs for, if this, then that, and coding and how that all works. And so it's really about understanding those workflows, to make sure that their processes make sense. And it's not even just the clinicians, it's also other business operations. So how would rev cycle function? How would finance function? How would human resources support the employees on that side of the house? I think it's a lot of different things.
Excellent. Monique, your thoughts?
I would just add to what Karen just mentioned. It's not just the security team or the CISO leading this charge. It's the clinicians, it's the operations, it's the business departments really coming together and developing plans for people, process, and technology. It's not just one group and it's not just one technology that's going to solve this problem or make an organization more resilient. And we've really focused on people, process, and technology at CHOP in terms of resiliency and planning continuity exercises to make sure that we not only have things documented, but we're also testing and we're retesting. So this also isn't just a snapshot in time. It needs to be matured over time, and it needs to evolve with your organization.
Monique, you talk about it being collaborative, and that makes a lot of sense. Um, what if you're a CISO in an organization and you don't feel like anyone's running with this at a high level, and you want to help identify this as a problem, but you don't want to own it from a big picture point. You want to be part of it, right? I want to tell everyone, hey, I want to raise the flag and say, this is a problem here. No one's owning this, but I don't want to own it because I shouldn't own it. So have any thoughts around that?
I would say partnership. Karen mentioned emergency preparedness and business continuity. They're the first two teams that I would reach out to and have a conversation, because this is an enterprise-wide hazard and an enterprise-wide risk. This isn't just information security. We consider cybersecurity risk, patient safety risk. So first and foremost, I would go to the business units, the continuity team, the emergency preparedness team, even my chief medical officer, I would reach out to and have a conversation about what the impact to patient care would be. The chief quality officer would be very interested in having this conversation around what could happen in the event of a cyber incident. So if there's not traction in whatever way that looks like in organizations, they're the first couple of executives that I would go to in order to start this conversation and really come up with examples and what other organizations are doing. Just don't come with a problem. Help develop the solution for the organization. Even if you don't want to run with it, you need to be a leader in that respect.
Yeah, very good. Chad, what are your thoughts?
Yeah, these really good thoughts from Keith, Karen, and Monique. Some of the same things that these guys are talking about, we hear a lot from the market as we're talking to customers and clients. And we really define it as where cyber resiliency is really where cybersecurity meets your operational or business continuity. And so you guys talked about those a lot. And when we go through and we look at a lot of those business continuity plans, as well as their cybersecurity strategy and how they handle things, there's usually a gap in between when you do a really nice job on the business impact analysis and business continuity planning, and then all of a sudden it jumps all the way to disaster recovery, and disaster recovery is kind of handled by your IT groups or your cybersecurity teams to go and recover and do that afterwards. But there's a lot of space in that gap, right, in terms of how you're going to keep that continuity of operations going. And we talk a lot with cyber resiliency is not just stopping the threat. To Monique's point, it's not necessarily about that. It's more about ensuring that continuity of care. And how do you do that when something goes wrong? And so making sure that, like to Karen's point, working with the clinicians, making sure that they understand that. We held a focus group at Vive this year with other healthcare providers, and the same message came out there was, we really have to understand exactly how our clinicians are coming out of school. How do they manage? How do they know how they're using these technology to actually provide care? And then what is the workaround? Because they don't necessarily know how to do that in a pen and paper type of environment. And so we need to make sure that they're trained on that. Like Monique mentioned, around the tabletops and things like that. How do they handle an environment when the systems are down, when they've been attacked? How do they go through and work in their day-to-day operations and providing that patient care when you don't have a technology or system available to do that? And so that's really where the resiliency comes in, and making sure that you've got that. All the while setting expectations that, yes, we're working on getting our systems back up, because that's usually where you get the phone calls to the CIOs and saying, and CISOs, and saying, hey, you guys said you're going to recover in 72 hours. It's been, 72 hours. When are we going to have this system back up? And so we've got to enable the operations to be able to operate and provide clinical care without the system, but as we're working through these recovery programs, and that really builds that resiliency for the organizations.
Excellent. Chad, let me ask you another question. And I don't know if this is a good analogy, but sometimes, I think that the clinicians are so dependent on the electronic systems that asking them to practice without them, well, certainly some of the systems, right? Some of the diagnostic systems like PACS and things like that, and medication dispensing. So you can almost get into a situation where we can't provide care the way we just can't, as opposed to the EHR, which is I'm uncomfortable providing care without this tool because I'm grown so accustomed to it. And I would ask if people could think of it perhaps like a carpenter being told to frame out a house without tools. You just don't do it. You say, I can't do it until you give me the tools back. And that's when, we know there's diversion. You divert patients. We're not taking patients anymore. And I always thought how intricate that discussion process and decision process must be, because you need to have voices from cybersecurity, from IT in general, from operations. You would have to have so many people at the table. And we know that decision has been made in the past. In your consulting that you do with people, do you get into the weeds into this kind of stuff to help people think this through?
We do. We act in a couple of different ways, either as a facilitator of those discussions to say, this is what's happening. A lot of times we like to do it in the preparation phase. So we're preparing for those things via tabletops or tests. We're talking through different scenarios. It's too late when an incident's already happened and we're trying to deal with that at the time. We can do it post-mortem after an event and go through lessons learned and obviously try to incorporate those types of things in place. But it's really about trying to focus on the preparation prior to that event happening and working through your tabletop events, or even going through and having a discussion around in your risk management program, how do we handle this type of risk and how do we work through that? And then actually making sure that you've got everybody at the table to have those decisions and make those decisions is really important. Oftentimes it's hard to decide who needs to be at the table, to your point, Anthony. And so we try to bring everybody to the table. And oftentimes when you bring everyone, there's really not space or air to make a decision because too many things they're being offered and they're all have competing priorities, and it's very difficult for leadership to make a decision around that. So we have to, in the early stages, really identify and understand who those main stakeholders need to be at the table, make sure they're there. They can obviously get feedback and input from their teams, but the entire team doesn't need to be at the table. We need to have the right decision makers at the table to make those decisions. So those types of pre-planning and facilitation of the communications prior to and the prep and the planning is really important for the resiliency discussions.
Keith, any thoughts around that? You can go so down the rabbit hole with the thought experiment on this, and I don't know if ever it becomes pointless or not useful, or maybe it is very useful. What are your thoughts?
I mean, I think it brings up 2 points. Is one, it's to I think Chad's point, it's the way I see it, it's the importance of actually testing the process. You can work on creating the perfect thing, but if you never actually take it out on the racetrack and see how it performs, you're not going to know where its strengths are, its weaknesses are, and how it's going to perform when it's called upon. And the second point is, we talk about going to paper like it's an acceptable alternative. I mean, in my opinion, it's a worst case scenario alternative. Just like if you have a jet engine and it loses the primary engine, you can certainly try and glide land it. But, when we do these drills, we should see, okay, we've got a solid paper manual process, but our goal should still be to create something that is the next step above that allows us to continue operations without this massive dip in quality. Because Karen mentioned earlier how physicians, nurses are being trained, and these are essential tools. I mean, it's a dangerous time to be in hospitals sometimes when these IT systems are not available, because so many safety checks, calculation checks are built into the IT systems that people just aren't prepared to do when they're doing it manual or on paper. So we've really got to be, okay, we got an emergency worst case scenario paper process, but what's going to be our long-term, strategy so that we're not going from A-level care to C-level care, because nobody wants to be in that scenario. You want to go from A to B+ care, whenever possible.
I think that's a great point, Keith. And I had always assumed it was, turn off DHR, go to paper, but you're making an excellent point that there should be other steps there. Karen, any thoughts?
Yeah, I mean, I think that's right. What Keith is saying is right. I think, paper should be a last resort. That doesn't mean that you should not think about it, I think, which I don't think that's what Keith is saying, but I think it's always important to think about like what are the other interim steps that could take place. And I think that's right. It goes back to also what Monique said, which is this is a patient safety issue at the end of the day. I mean, from a clinician standpoint, when you have nurses who are relying on medical records to help them make medication calculations or things like that, like they're not getting that type of training anymore in nursing school. So some of that is being done on the job by nurses, who have had to do that before. And, the workforce is not supporting that as much because those people are retiring. And so I think, having to be able to have processes or templates of things, I think can help. But I do think that Keith is right. It has to be tested in some way. Also, Chad is right, where you have to bring the right people to the table because you can't bring everybody all the time. But I do think that many times departments can operate in silos. And so, when you start to think about disaster recovery planning and then business continuity and all the things that go along with it, I think departments tend to think first and only about themselves and how they might function until you push them to understand how that is connected with every other department. And I think that's where the testing comes, because I think people, can do generally a good enough job understanding their own department workflows or where they might have difficulties. Or I think you mentioned, Anthony, early on, like there may be some types of services that just can't be done safely. And so making those decisions, I think, makes sense. But I do think there has to be some point where the clinicians from different clinical departments interact with each other, but also the business interacts with each other. So how does revenue cycle then interact with pharmacy to bill for medications and all of these things that people just haven't thought about unless something happens?
Yeah, Monique, I've heard stories in other discussions like this about how testing can reveal, they have the epiphany of, oh yeah, of course that wouldn't work because that system's down, but we assumed it would work. We assumed this would work, but it doesn't. So that can be pretty valuable for opening eyes on some things that aren't maybe intuitive.
Yes. And are you talking relating to disaster recovery and
Yeah.
recovering systems? Yes, and that's something that needs to be focused on just as much as continuity planning is the disaster recovery work. And how do we recover systems? How long it's going to take? What's the order of operations or order of restore? And to your point, Anthony, testing is so important around that. Does it actually work as designed? And it's in healthcare, it's a challenge to test all the critical applications and even get critical applications down to a testable amount. But it absolutely is necessary, even if individual organizations start with the electronic medical record and making sure that the documents to rebuild the application or recover the application are there, the backups work, and the backups are tested on an annual basis is really necessary in order to ensure that the disaster recovery planning is in place, at least for the top tier application. But my recommendation is to work on what are the critical applications for an organization and work on plans for each of them, not only to document them, to test them on an annual basis. And it's not only testing the rebuild, it's testing the data that's on the backups and making sure that it is recoverable and functional. And that's just not the technology teams doing that or the security teams doing that. That's in conjunction with all of the business and clinical leaders that we've been talking about and teams, because they need to test it to make sure that it's functional for them to do their work.
Keith, you want to jump in?
Yeah, I just wanted to add another thing that we're trying to do is add the Bob test, if you will. We all have a Bob, that person who knows how everything works and they're the go-to person. And inevitably, when you have an event of some type, Bob is on vacation or Bob is out sick. So we're trying to integrate that into our testing. Okay, this bad thing happened, but guess what? Something else bad happened, or another bad thing happened. And how are we going to recover when Bob is on vacation? So we're not trying to fly him back from Hawaii or whatever it happens to be. And I think that's something we have to do too, is test our teams, not just our process and our data, because Monique, you're hitting on excellent points. But inevitably, I don't know, maybe it's just me, other bad things seem to happen in clusters for us. So I want to try and prepare for that worst case scenario. So when my primary parachute goes, I've got a second, and when that one goes, I got a third. So that's what we're thinking.
Yeah, spot on, Keith. I literally 2 hours ago just had a conversation about an upcoming tabletop where we're going to excuse people from the room to say, you're on vacation, it's 2 o'clock in the morning, it's Memorial Day weekend, to make sure that we are looking out for the Bobs and testing that aspect. So nice point.
Wow, that was excellent. The Bobs, I love that. I
I
love that.
love it too. Yeah, it's great.
Chad, let me go to you. A couple interesting points here. And oftentimes it's the human stuff that's the hardest stuff here. It's not the technology. Um, getting so to do a good tabletops, the whole Bob element is really interesting, and I hadn't thought of that. That's brilliant. Um, let's say you're involved with setting up a tabletop, and you can't get everyone you want for that tabletop. You're trying to schedule it so people are always busy. You can't get the critical people you want. First of all, you have to figure out who the critical people are. And then you have to get them to participate, and you have to pull it off, because you can't say, "Oh, it's not working out. We'll come back and do it again." It's really hard to get all these high level people together, and then you have to give them you almost need a governance for the incident, right? You have your regular, all kinds of governance. There's committees everywhere. You almost need to think out and say, as you mentioned, how are we going to make a decision here? Who are the critical voices? Is the FBI here? Is our cyber insurance company at the table? Is Bob on vacation, right? All these kind of things. So there's a tremendous amount of complexity here. Uh, to setting yourself up to have some clue of how to move forward when something happens. What are your thoughts?
Yeah, my thoughts are you're exactly right. That's very difficult. It's a bit like herding cats, the old saying. Yeah. So it's difficult to get everyone at the table, the time you need them there at the table to have a good conversation. And then even if you have the right people at the table or participating in workshops or in a tabletop, sometimes they're not engaged. Sometimes they're not fully, they don't want to be there. They have other things on their mind. They have other priorities. They view this as solely as a check the box type of activity, and they would rather be somewhere else. And a lot of times they are. You'll see them on their phone, or they go to breaks and they keep coming back later and later from a break. And then before you know it, they don't even come back for a break, And so it gets very difficult to try and get folks engaged early. I think what we try to do is really lay the groundwork for the importance of the actual workshops and get leadership buy-in from that. I think that's important as well. We invite leadership to come in to the beginnings of the workshops to actually address the teams, to say, hey, this is why we're doing this. This is why it's important. This is why we're talking about cyber resiliency. And this is why this particular activity and you have been invited to this to participate and asked to participate, because your job is critical for us to succeed in this, and really setting that expectation. And then we pick up from leadership's message and say, this is what leadership would like for us to do. We try to get these things engaged. We also play a little bit of games with the participants at times. So we try to find the folks like Monique was mentioned, or like Keith was saying about the Bobs. If we have one person who's sort of taking over the workshop, answering all the questions and sort of doing that, we find a way to excuse them. So say, hey, okay, let's try a scenario where we're going to ask Keith to leave, and then let's see how we can deal with it from there, right? And sort of almost forcing the participants to interact and work together without that that overbearing type of personality who's in there, trying to take over and take control of the workshop, and really driving the interpersonal relationships down. Sometimes that happens, right? And you have to be careful with that as well. And then when you get all of these leaders at the table, oftentimes you do have a person who's maybe an individual contributor, or who's someone who has a lower pay scale, for lack of a better word, and they're nervous to speak up in these types of environments. But we need them to speak up because they have a very important part to play. And so we try to be very cognizant with that in the beginning, and how we're going to deal with this type of dynamics if in fact it comes up, using experience and things that we've seen in past workshops, and trying to help really stem the conversation that needs to take place to ensure that we can recover and respond to events, and make sure that we're testing these workshop and testing our environments. I thought it was really important. Monique said, testing the actual data. You'd be surprised how many times we talk to customers about whether or not they have actually tested those backups. And 90% of them say, no, I don't even know how we would do that. Right. We just have a plan to do it, but we've never really done it. And so it's important to do that, getting the people there at the conversation to say, yes, we can do it, and we will do it, and this is how we would do it. And walking through that process is important as well.
Keith?
The one point I wanted to add too is, and I think those are great points, is also symbolically, if you participate in their tabletops and their quality activities, I think they're a lot more likely to participate in yours as well, because it demonstrates like a mutual caring. So we participate in patient safety huddles, the tabletops that physical security runs. So, we want to establish that culture that we're not just around when it benefits us, we're around to help them, because ultimately we're one system, and patient safety comes in a lot of different forms. And through that partnership there, I think it sets that goodwill, which will drive a lot more participation down the road, and engagement.
And I love that. I'm going to go right to you, Karen. I just want to make the point that I love that, Keith. And that's not part of a cybersecurity credential or license. Got nothing to do with that, right? The dynamic you just talked about, that's leadership. That's high level executive thinking, right? So that's the hard part, is how do we get people to cooperate and engage when we can't force them? We got to get them to want to be part of this. Karen?
No, I was just going to say, Keith is absolutely right. I don't think the first time we should ever be approaching anybody is to talk about a tabletop exercise or a downtime. I mean, we should be engaging about numerous other things before we ever even get to that. Like, how was your weekend, or how are things going for you? That relationship building, I think, is so incredibly important. I also wanted to mention, I think this concept of what I sort of call in my institution sort of succession planning for people. So like, not every leader is always going to be there all the time. And so who are the people that succeed you? Like, who will make decisions on your behalf if you are out, or we just cannot get a hold of you, or maybe we don't need to get a hold of you because it's not that urgent, but we need people to make certain types of decisions. So I think those kinds of questions force our other leaders to think about what those succession plans, and I don't mean like termination succession plans, but
No.
just like business succession planning. So I think that's important. And in terms of like tabletops, I sort of think about, I hear a lot of people think like, you should be doing this on average once a year. That's what people tell me. But I think that I sort of see this in a number of different work streams, really. So maybe, everybody should be trying to get together in leadership once a year at minimum. But I think that there needs to be a number of different exercises running in tandem. So things at each individual department level. And that is, like we've already talked about, each of the clinical departments, the operational departments. For some of us, research academic departments also need to think about that. So things, like clinical trials research, or how would that work? So there's that piece. And then I think there's this other work stream of just IT by itself. So how security interacts with the larger IT team for things, like downtimes or recoveries, or extended downtimes, I should say. And then what does that look like at the HICS level? And I think, most of us have been through COVID, so we know we are pretty familiar with HICS now. But, that's something certainly people leverage during times, of these kinds of things. But the HICS structure isn't generally set up for IT issues, right? It's usually set up for clinical care types of things. The structure makes sense, but it's just a different version of it. And so I think some of the decisions to be made are slightly different, but need to be talked about. So that's kind of the way I think about it.
Very good. Monique, anything you want to jump in on?
Sure, I would just add another group to practice the exercises is the executive team and potentially the board of directors, making sure that everyone's aware of their roles and responsibilities, that they're asking the difficult questions, understanding that there's going to be difficult answers and responses back, that they're working through different scenarios. Who pays the ransom? When do we communicate with the board? Who's giving them updates on a regular basis? The list of questions goes on and on. But the important thing is that you're building muscle memory with the executive team on what's going to happen during a cyber event and how to ask those questions in a crisis situation.
So Monique, and I was going to ask this. It's important, and I think this is what you're saying. It's important to manage up and to prepare your CEO, your COO, and the board, prepare them to be successful in making decisions when this happens, to get them thinking about what this could look like and some of the decisions they might have to make and some of the people they might need to make those decisions in collaboration with. And that's part of supporting or being a good managing up well and putting them in a position to be successful. And that's part of your job. Does that make sense?
Absolutely. I wouldn't call it managing up, though. We're all a part of the same leadership team and the executive leadership team. So it's definitely part of my role in being that a security leader within the executive team and making sure that they're prepared and that they know their roles and responsibilities during an attack.
Right. Yeah. Because they get hit with it cold, and it could be like, well, why did I have no idea how this was going to go down? Anybody else want to comment on that dynamic?
I mean, I think ultimately Monique is right. I mean, I think many times though, leaders our peer lead. Monique is right. There are peers. So our peer leaders are going to turn in this type of situation. They're going to turn to us for questions like, should we pay the ransom? Like, even though I think most of us on this panel probably think this is not a solely a CISO decision, but I mean, they're gonna look to us for some level of, what do you think? Or, how bad do you think this is? Or, what kind of backup do we have? And so helping to have those conversations in advance probably help the situation. So you're not doing it in the moment.
Right. And so Keith, let me run this one by you. Again, I think of the tremendous collaboration that has to be had in real time between someone like yourself and the chief medical officer. So, for example, you could say, here are the systems that are going to be impacted. Here's what I have to do from a technology point of view. I have to take this offline. I have to take that offline. Here are the impacts. Here's the possible duration. And then they have to make the determination of the impact on patient care. You're not going to do that. You explain it to them. You give them your best idea of what's going to happen. They have to then figure out what that means to patient care. And then maybe somebody other CEO has to make a decision again when we get down to diversion, right? But it's really an intricate real-time discussion where you're providing input and they're providing input. Your thoughts?
Oh, no, I completely agree. You get to a large incident and it is, it's the duty of every executive to step up and to manage for their respective scope of responsibility, because an organization is going to have to move through an event like that. And the CMIO, the CMO, all of the different leadership levels have their part to play, because they're part of the organization that's going to navigate through it as well. I think one thing that is interesting to consider is sometimes IT and cyber maybe create more of the background of the incident than we could or we should. And I've been kind of contemplating, what if I go to the chief medical officer and say, okay, you have to lose a big system. Which one's it going to be? Because we always go towards the EMR, but they may pick different things. And that's another way to change the dynamics of the test to get them involved. But then also, we always seem to look at what happens if the bad guy comes through the front door. Well, it's not always going to be that way. So we're just trying to change things to bring the executives more into the process, so that it's not just they're going to be here at the beginning and at the end, but let's try and keep them through the whole process and their teams, because that's probably what it's going to actually be like when the big bad event happens. That it's an all hands on deck for everybody in every department throughout the duration of the event as we navigate through it, because it's really hard to think that a cyber event is going to be really siloed and say it's just going to impact radiology. Everybody else is completely okay. You can go home. We'll probably get this fixed by the weekend. And that's just, I don't think that's real.
Chad, let me run the idea of biomedical equipment by you, right? All outages are not equal, and all systems you have to take offline are not equal. And what comes up with biomedical equipment is you can't just shut it off, because number one, we don't know where it all is. It's hard to track. It's all over the place, pumps, this and that, and we don't know what's hooked up to a person. I don't know how often that would come up in a cyber incident where we need to take biomedical equipment, or we would like to take biomedical equipment offline. But that's another wrinkle to this, isn't it?
It is. It's a major challenge, and one that continues to get a lot of airtime in discussion around risk management and how are we going to deal with these medical devices. Um, we see a lot of parallels to the industrial automation industry as well, because there's lots of old legacy equipment that's out there. How do you deal with those legacy risks? And medical equipment can be the same way. Some of them can't actually, you can't patch it, it's not feasible. Some of it has to have compensating controls around it. We have to incorporate some sort of isolation for those devices. Even HIPAA is getting involved with putting some language into the latest round of HIPAA language for segmentation. So validating that you have network segmentation for a lot of this medical device. So if you in fact do have a medical device that has been compromised, how can you segment it? How can you isolate it? Keep it off of your main network so that that doesn't spread to other areas of your environment. So being able to do that is really important, and we're starting to see more conversation around how do we get that done? How do we incorporate that segmentation? And then not just saying we have it, but then validating it, verifying that your segmentation. So very similar to the way we were talking about doing backups and recovery. How do we validate and verify that we have a segmentation on our networks to be able to isolate those devices? So when we're running through tests, we have to incorporate that into our regular process to ensure that we can, in fact, isolate something that has been compromised. So can we take, from a technical assessment, can we go ahead and take a device and see if we can isolate it, given the scenario that one of those devices have been compromised? And so it becomes a big challenge. We're not seeing a lot of folks doing this yet, but this is coming in terms of the regulatory requirements, as well as the leadership looking at this from an enterprise risk management perspective to say, how are we dealing with these medical devices, and how do we keep up with not just taking the medical device, understanding what the configuration items are, how do we run vulnerability management against these types of devices, and then how are we handling the patching and then the isolation of those devices as well.
Excellent. All right, we're going to go to my favorite section to see what you folks want to learn about and hear from each other. Chad, I'm going to let you go first. Do you have a question for one or multiple of your co-panelists?
Yeah, I mean, I would love if we have time to hear from each panelist around my question, because it's such an important question for us to really understand how your particular roles are communicating with your boards and executive teams. you look at it as from an executive team or an ELT type of leadership role. You sit at the table with those teams, but when you look at reporting up to the board and executive teams and around risk and cyber risk, how are you engaging with those, and what messages are most resonating with them? So when we talk about cyber resiliency, we really look at it from this is a risk to the business, and the business is providing patient care. Obviously, that's a big priority. But how are you tabling that and shaping that conversation with the boards and the executive teams to ensure that it truly becomes a business risk and cyber becomes an enabler, not just a cost center that we usually look at it as?
Monique, let's start with you.
So I have the opportunity to report to the board every quarter. They're very much interested in cybersecurity and the threat landscape. So typically I go over the threat landscape, what we're seeing at CHOP, what we're doing at CHOP about the threat landscape, and also what we're doing in terms of our top risks. They're very interested. I don't have the issue that they're not interested, and they're, especially with the executive team and the board of directors, I'll put that out there. They want regular updates. I provide evaluation on how we look at the assessments, the prioritization of risks, and how that equates to our investment in our program. I also benchmark against industry standards, typically Gartner, but it's very important to show where our risks are, what we're spending on them, and how we can get to a return on investment. So that's a constant conversation quarter after quarter that I have with the board of directors. And the executive team, I pretty much regularly talk to them each month around the investments we're making, cyber insurance, the different aspects of our risks and our continuity plans. So that's how we do it at Children's Hospital of Philadelphia. And it really makes me proud to say that the executive team and the board of directors are so much in line and care about the cybersecurity aspects, and it's not a battle.
That's great.
Very good, Karen.
Yeah, very similar to Monique. So I have a forum with our executive leadership team every month. I present to the board quarterly, same. A lot of the same things that Monique talks about to the board. I'm presenting as well. I spend a lot of time also talking about benchmarks. So these are our capabilities. Here's what some might be doing better or not. Where I would like to be. They are extraordinarily engaged. Cyber and privacy also separately are part of our enterprise risk framework. So they are verticals as part of it. And so cyber is one of the top 5 ERMs from business risk that we track to. So there's a lot of interest in that here. They ask me a lot, do I feel, well resourced? Am I well funded? Am I getting what I need? So I think probably gone are the days when maybe leadership and board are not as invested. I mean, I think it's an investment, I think, for most, and including where I'm at.
Keith?
Yeah, I would agree with all that, and I'm lucky to say that our board is very engaged as well. The one thing I would add is that, I'm trying to make sure that we don't talk about products, we talk about the program. And, they see that they're making an investment in something that's durable and that will continue to grow over time, so they don't feel like, I don't want them to feel like it's an out of sight, out of mind, or it's a one-time cost. I want them to know that what we're creating has sustaining value, and it's integral to the mission of the organization. And I think that helps to elevate the conversation, that it's less of IT people talking about IT things and more business executives talking to other business executives about the things that will help the business stay successful, and to be successful long term, and to keep our patients safe. So.
All right, very good.
Thank you.
All right, excellent. Monique, Karen, or Keith, do you have a question? I usually call on people, but I don't think we have enough time to get to everyone. So do any of you have a specific question you want to get in front of your co-panelists?
I'll jump in here. So one thing that we're working on is a well-being initiative across CHOP. It's not just for information security. But, I've been taking that into the information security lens and the program around cyber resilience and how we react in a cyber event and how we take care of our teams within a cyber event. So at CHOP, there's a model called the zones where we pinpoint what zone we're in at a specific time. So if somebody's in crisis, they can pinpoint that and work through what plan they need to support their well-being during that crisis. It's very similar to a mass casualty event and what our clinicians use. So I'm bringing that to the information security program to work through this in a safe space before a major cyber event and talk about well-being. And I'm just curious if any of you are having those same conversations with your teams.
Karen?
Well, I mean, I wouldn't say to that of a defined extent, but I love that concept and I want to talk with you offline about it because it's really good. I worry about just general well-being of the cyber team because I feel like they are always on. And so I've been failing much of the time, I think, but like trying to hold maybe emails after hours that aren't urgent because I think when I send things, people want to get back to me and I'm like, this is your time off or the weekend or, and what I used to do is say like, no need to get back to me until tomorrow or till Monday or whatever, but nobody listens to that. And so I don't want people to feel like they have to be constantly on. And so I think that concept you're talking about, Monique, is very real for our teams, and it's exhausting, I think, for them too, outside of a crisis. I mean, then I don't want them to be exhausted when we're in a crisis then because they've been on all the time. So kudos to you. That program sounds great.
Yeah, that was good. My question is, where can I get a copy of that?
I'll definitely reach out to both of you offline.
The one thing I would add to that is I think that I'm trying to combat that stigma of perfection where all cyber has to be perfect. Yeah, there's every day you have to get it right 100% of the time or, but I mean, that's not a healthy way to operate long term. And that's where I think the team model is important so that we don't have people feeling like they're the only ones standing on the wall keeping us safe. That's why we have a team. And there are times where the team won't be able to catch everything. And that's why we have to build multiple levels of controls and contingency plans so that we can be human and not try and be robots because that will ultimately not work. And I want people to enjoy their career and their life here and not feel like this is a sentence. And I want them to be happy about what they're doing and engaged in the mission. And I think that's once you can kind of de-perfectize the mindset, then I think you're able to enjoy your job again and the mission that you do.
Brilliant. Chad?
Yeah, I love the conversation around well-being, and I think it's really great. We have the same issues on our side as well. We have to always be on, right? So there's a level of expectation from our customers that if we call, you're there. You have to be very responsive and attentive to the needs of our clients. Similar to, when you're providing patient care, right? If a patient needs your help, then you have to be there. We try to work with our security operations analysts a lot to make sure that we understand what their well-being is. We don't have a formal program similar to the way that Monique outlined, but very intriguing. And I think it's something that we constantly have to check the pulse of how everyone's doing in a particular situation. So if a particular team has had an exceptionally tough week, then we need to check the pulse, see how we can shift workflows off to other teams and pick up the slack where we give those teams a little bit of time to take a break. And so it's a constant process to continually improve that and check the pulse of the health of our teams. So great conversation.
Yeah, and a great point, Monique. The different incidents I've read about, often you read about people being up for 3 days without sleep, and that's not ideal. And the interesting thing is when a leader does it, but doesn't expect it of their team, I don't think that works all the time because if they see you doing it, they think that's the behavior that you want them to emulate. And so it's almost like you have to have the balance if you want them to feel the freedom to have the balance, right? So go ahead,
There's
Monique.
definitely a lead by example there.
Yeah,
I think that's
yeah.
right. Yeah.
Awesome. Listen, we are about out of time. It was a brilliant, brilliant discussion. A lot of fun. Regarding continuing education, you can use the final slide in this deck. If you the on-demand recording of this will be sent out. We'll send out an email as soon as that's ready. If you want to work with us, you can reach out to Nancy Wilcox from our team and go to our website to register for upcoming panels. With that, I want to thank our wonderful, tremendous, fun panel: Keith Duemling, Monique St. John, Karen Habercoss, and Chad Alessi and CTG for sponsoring, and you for attending. And with that, everybody have a wonderful day. Thank you.
Thanks, everyone.
Thanks, everyone.